I'd like to invite Lou Martin to return to the podium to talk about evaluation of new interventional devices, or new interventional technologies and devices. This is something that Lou has written on for the Society for Interventional Radiology. And there's no shortage of new devices and new techniques. How do we figure out the right ones? Because I had 5 different people telling me just the right one. What do I do?
I want to go home early. It shows you should never write an article about, that you might have to defend 15 years later. I'll have to say that I'm very skeptical about, well, I'll plead that I'm very ignorant. I was going to say completely ignorant. I don't think I'm completely ignorant, but very ignorant on exactly how to evaluate technology. I think that the trials that are done on new technologies have to be examined statistically by a statistician, and I know nothing about statistics, and I never will, I'm sure. Let me go through some of this. I'm going to run through some of it a little bit faster, and what I'm going to try to do is transmit some of my skepticism to you, and so that probably at the end of this you'll know much less than you do now and probably ever wanted to know. I am a consultant for Neelix Endovascular, and we're not going to really discuss that. I didn't know when I started whether I was going to bring some of their things in, but I have no other conflict of interest that pertains to this talk. And the general principles of this evaluation for the development of valid conclusions regarding the efficacy of a device or technology, there are fundamental principles and certain requirements. And the purpose of the study should be to answer a well-defined question or a hypothesis about a device or a technology. So you have to make sure that when you're reviewing an article about it, that they really are very definite and they've characterized what they're trying to do. It's required that you have an appropriate selection of subjects and controls and clear and consistent definitions used in describing the results of the intervention. Clear interpretation of the results and statistical evaluation, and that bias has to be controlled, and that there are clear and attainable endpoints. These all seem fairly simple, but frequently these are violated and these requirements aren't present. Now, do you consider the study to be valid? There are 2 types of validity, and one's an internal validity, and that reflects the true effect in the particular group that's being studied. And the thing that we're really interested in is a more generalized or external validity. Are the results of this study applicable to a more general population? Because that's usually a much more serious point. The study design, the ideal study design, and what we're always trying to achieve is the randomized controlled trial. We would like it blinded. We would like the person doing the evaluation to be blinded as to whether the patient or the control received the therapy or the device was used upon them. And we'd also like the patient to be blinded so that we don't have a placebo effect. And those things are incredibly hard to achieve. It's amazingly expensive, and almost every trial that I've been associated with has had a terribly tough time to select the patients and to get the patients into the trial and to take it to completion. And usually a lot of the qualifications and principles of the trial are violated during the trying to draw patients into the trial. So the study controls, the randomized control trial, I went over that. There's a non-randomized control trial with contemporaneous control, historical control, registries, case series, prospective, retrospective, or pilot studies, or meta-analysis of the above. And one of my other, as much as I disdain the randomized control trial, just because I feel that it's unattainable essentially, the meta-analysis that, if you garbage in, garbage out. So you have somebody that's taking a look at it's really difficult to find out whether a controlled trial has really been run according to the edicts that they had decided. But when you take a registry and you're taking a look at a meta-analysis of 20 controlled trials and trying to figure out whether they all didn't violate the tenets of their trial, it's virtually impossible to figure it out. And so I think you get a general idea from this and not anything that's very specific. Study population and patient population must describe who, how, why, and when the subjects were selected. They have to state the exclusion criteria, and it must be based on intent to treat. I've got a recent patient that I was referred to, one of my vascular surgeons referred a patient to me to treat a stenosis of the left subclavian artery. They had to go on to bypass. So I went up to see the patient the night before the procedure and talked to the patient and obtained a consent. The patient had some potassium problems the next morning, and so we had to delay the procedure for another 24 hours. Patient stroked the night after I had talked to her, and so that was my complication according to the intent to treat. So I have a stroke. I caused a stroke by intending to treat that patient, and that's what intent to treat means. And so intent to treat and crossover in trials are two things that make them incredibly hard to evaluate. Well, the data, of course, the type of data and how it's collected and evaluated should be described before the study begins and not after it. And you really should adhere to the principles that have been determined prior to the study and on these collections. In the 1990s, atherectomy was portrayed as a significant advance over balloon angioplasty in several large case series. And we were very enthusiastic about it. I was one of the enthusiasts. And the atherectomies at those times were done with the Simpson atherectomy device, which is really it's a very good catheter. It takes out very good slices of the atheroma. Basically, there's a chamber on the Simpson atherectomy here, that a little thing, and there's a little cylinder that rotates in that chamber and comes down and cuts the atheroma, which protrudes into the chamber. And on the opposite side of the chamber, there's a balloon here. And so what you basically do is locate the atheroma, blow up the balloon so that it presses the chamber against the atheroma, and then slice it off. And it worked very well. Unfortunately, it didn't show any positive effect over time. And subsequent investigation showed that it was no better than balloon angioplasty. In fact, in many cases, it was worse than balloon angioplasty on several trials. Now we have the resurgence of the atherectomy devices. We have numerous atherectomy devices here, and I know that John Laird might like to comment on this later. And I know he's been involved with studying a lot of these. And it's not that I'm saying that they aren't any good or that they shouldn't be used. And they possibly some of them are good and should be used, but thus far there are no randomized trials on any of these new devices. Now, so is the randomized control trial the Holy Grail? Is it really necessary? It's very expensive, it's time-consuming, it's very difficult to see through to its fruition. Is it fact or myth? The use of the randomization allows for valid statistical treatment of a variation between controls and subjects. Statistical analysis serves as a check in the homogeneity of the two groups and therefore on the quality of the randomization. Well, maybe it would if it were very clear, if you could control these things, but a lot of times we can't control them. This is a study that I was involved with, and we thought it was a very good study. It was a study on dialysis grafts, and we took a series of patients with greater than 50% stenosis within the dialysis graft and randomized them to either balloon angioplasty as many times as we wanted to treat them, or no treatment at all. And we took a look, and the endpoint of the study was failure of the graft to sustain dialysis. And it was ultimately reported by Dr. Lumsden and as me and others in the Journal of Vascular Surgery. And the title tells the result that prophylactic balloon angioplasty failed to prolong the patency of expanded PTFE AV grafts, and a result of this prospective randomized trial. It turned out that the groups weren't quite as homogeneous as we hoped. There were 60 in each group, so there was a large number of patients in the patient populations. I'm sorry, there was I think there were 32 patients in each group. There were 64 total. And it turns out that there was absolutely no difference in the survival of the graft in these two groups. So that was the endpoint of the study, and it proved failure. However, when we took a better look at it, there was a disparity in the groups, and that wasn't originally apparent. And we looked at it after the statistician had made this evaluation, and it turned out that some of the patients were fixed for the first time, so they had an angioplasty on for the first time. We have what we call a virgin in the PTFE graft, and that's a graft that's been placed surgically and has never been intervened on. And then, so some of the patients among the 32 in each group were virgin grafts, and it turned out that the virgin grafts were much more prevalent in the control group than they were in the group that were receiving angioplasty. So there were 8 patients in the control group, in the treatment group, and 13 in the control group that had it. And then the patients in the virgin group had up to 3, in the control group, the treatment group had up to 3 angioplasties before they were admitted into the study. It turned out that these groups really, the sum total was that it turned out that the two groups actually weren't the same, and statistically they weren't relevant. Another thing is the Warren shot, and I sort of have a conflict of interest to declare according to Dr. Warren. I worked with him for over 20 years and really believed almost everything that he said, and a lot of you won't be familiar with the Warren shot, but Emory became quite a center for treatment of portal hypertension. And Warren went ahead and had several prospectively randomized trials between the Warren shot and which is a selective shot, and non-selective shots. This is an H graft, a mesocaval shot to control portal hypertension. And what's happening in this shot is that there's a graft that's being placed between the superior mesenteric vein and the vena cava. And so that all of the hypertension, or all the blood from the portal circulation, can bypass the liver, and it goes back into the vena cava and circulates back up to the heart and for recirculation. Well, Warren contended that this wasn't good for the patient, that the liver had there was detrimental to the liver, the health of the liver, and longevity wasn't as good in this in the total shot as it was with selective shot. Now the selective shot, and you'll have to ignore the thrombus in this shot. It's the only one that I could find for the thing. But what happens in this is here's the superior mesenteric vein and going into the portal vein up to the liver, which is carrying all the mesenteric flow back up to the liver. Well, this is preserved in the Warren shot. So this is, but what they do is ligate and subdivide the splenic vein over here, and then hook that into the renal vein. So what happens is that it's taking all the splenic flow and placing that into the renal vein and bypassing. That doesn't go back into the liver. And then any other collateral circulation up here in the coronary veins goes back into this left side and comes back up. So he decompresses the varices, gastric and esophageal varices, while preserving liver flow. And that was the premise of Warren's shot. Emory's perspective, he did this trial, 10-year follow-up on documents, so its selective shot was much better than the non-selective shot, controlled bleeding, and we took this to the bank and held this. We recently did a study taking a look at TIPS versus DSRS. The distal splenorenal shunt is the Warren shunt. And so the TIPS procedure is a complete shunt. So it really should have the same results as the 10-year study that Warren had, because we're looking at the TIPS as a total shunt. There's no perfusion of the intrahepatic portal circulation after a TIPS procedure. And so we took and prospectively randomized patients to having either the Warren shunt or TIPS. And we found out a lot of things to our surprise in this. We thought that preserving flow to the liver prevented encephalopathy. Well, it turned out that there was no difference in the number of significant first encephalopathic events between the two groups. Survival at 2 and 5 years were not significantly different between those two groups. The accumulation of ascites and need for transplant and quality of life and costs were not significantly different between these two. And the thrombosis and reintervention rates were significantly higher in the TIPS groups, which you might expect, but nevertheless, there really wasn't much difference other than that. And the TIPS even actually turned out to be a little bit cheaper than the DSRS. The conclusion then is the TIPS may be a high maintenance shunt, but it preserves liver function and should be good for long-term control of variceal bleeding, and that it has survival benefit. But this really isn't the whole story. This is a prospectively randomized controlled trial that was supported by the NIH that took 4 or 5 years to perform, and then we had to wait another 5 years to make sure that everybody got through 5 years of follow-up on the study, and came out with this conclusion, but the conclusion's flawed. Does the conclusion of our study mean that TIPS was now the preferred treatment to preserve liver function and survival in child's Class A cirrhotic patients? That was the group that we were studying, who's not a candidate for liver transplant. Does this trial contradict the results of the previous one? Well, it turns out that the flaw was that these were non-covered stents that we're using in the TIPS. Now we're using covered stents for the TIPS. And they were always failing, so that within 9 months, 81% of the patients had to be re-intervened on. And so it really wasn't a total shunt. That we weren't looking at a selective shunt to a total shunt. We were looking at, more or less, we were looking at 2 selective shunts, because the flow through the TIP shunt was never as good as when we got done with the procedure. It started to fail almost immediately and then had to be re-intervened upon. And so then we had to go ahead during the progress of the study to keep re-intervening on the TIP shunt. And by doing that, we were able to get this parallel and equal response. But nevertheless, it wasn't really what was proposed by the study and what the study conclusion indicated. So since the TIPS was always failing and therefore not analogous to the total shunt, the hepatic perfusion was actually preserved by the failing TIP shunt, and so the TIPS was functioning as a hybrid between these two things. And as I said, that was the old TIPS. It's not even the new TIPS. So really it was sort of a study that took close to 7 years and millions of dollars to do, which was fairly worthless at the end. Anyway, the final message, I guess, probably, and it's not a very satisfactory one because I wish I could give you a more definite answer, is really that you have to read between the lines and make sure that the study is relevant to your practice, whatever you're to be suspicious if it contradicts common sense or your past experience or the past experience that's been reported in the literature. Don't be the first to jump onto the bandwagon after some of these studies make it into the publications, and make sure that you're comparing apples. Thank you very much. By a statistician, and I know nothing about statistics, and I never will, I'm sure. Let me go through some of this. I'm going to run through some of it a little bit faster and what I'm going to try to do is transmit some of my skepticism to you, and so that probably at the end of this you'll know much less than you do now and probably ever wanted to know. I am a consultant for Neelix Endovascular, and we're not going to really discuss that. I didn't know when I started whether I was going to bring some of their things in, but I have no other conflict of interest that pertains to this talk. And the general principles of this evaluation for the development of valid conclusions regarding the efficacy of a device or technology, there are fundamental principles and certain requirements. And the purpose of the study should be to, I'll have to say that I'm very skeptical about, well, I'll plead that I'm very ignorant. I was going to say completely ignorant. I don't think I'm completely ignorant, but very ignorant on exactly how to evaluate technology. I think that the trials that are done on new technologies have to be examined statistically.
This is something that Lou has written on for the Society for Interventional Radiology. And there's no shortage of new devices and new techniques. How do we figure out the right ones? Because I had 5 different people telling me just the right one. What do I do?
I want to go home early. It shows you should never write an article about, that you might have to defend 15 years later.
I'd like to invite Lou Martin to return to the podium to talk about evaluation of new interventional devices or new interventional technologies and devices. This is